Good morning, everybody. We're going to talk about sore throat today. In order to go to the topic, we have first of all, we have to give a hint on anatomy of the pharynx, diagnosis of sore throat, differential diagnosis of sore throat, prodroma, clinical skills, eliciting sign to complete your diagnosis. Start with the anatomy. First of all, you have to know how to use a tongue depressor in order to examine the oral cavity and the pharynx. Tongue depressor is a wooden tongue depressor is very weak. Tongue is very muscular. So try to catch the tongue depressor by your non-dominant hand, catch it from its middle, put it over the anterior half of the tongue. Don't push the tongue down and let the patient say ah. If you do this maneuver, the palate will go up and the tongue will go down and the pharynx will be in front of you, the oropharynx and the oral cavity. This is a check, upper and lower lips, palate, tongue, oropharyngeal isthmus, much close, palatoglossal fold, the mucous membrane fold, harboring palatoglossal muscle inside it, and beneath is the palatopharyngeal folds coming from the palate inserted in the lateral wall of the pharynx, harboring a palatopharyngeal muscle. Between the two folds, there is a palatine tonsil. This is the oropharyngeal isthmus separating the oral cavity from the pharyngeal cavity. In order to go to the pharynx, we pass through the oral cavity. The oral cavity is divided into two components. First is the oral cavity proper or mouth cavity proper, which lies interior to the teeth, and the vestibule of the mouth, which lies exterior to the teeth. More close, we find in front of you a round opening, which is a Stenson duct orifice or babilla of the Stenson duct, babilla of the parotid duct. You have to know the exact site of it because the significance of this punctum, it transmits or give an idea about the pathology of the parotid. So by simple milking of the parotid, something comes from the parotid, either serous, blood, or pus, according to the situation of the pathology inside the parotid. So we have to know the exact site of it. It's opposite the upper second molar. The pharynx is divided into three parts: nasopharynx behind the nose, oropharynx behind the oral cavity, laryngopharynx behind the larynx. We come to the lateral wall of the nasopharynx. Here, behind the nose, the lateral wall of the nasopharynx, we have very important structure, which is a pharyngeal orifice of the Stackian tube. Stackian tube is not always open and not always closed. It opens only in certain circumstances, in yawning, swallowing, and on speech. So it equalizes the pressure of the middle ear to the atmospheric pressure. So it needs anchorage of muscles to open it. In order to do that, there is a tubal elevation above and behind it, like a hockey stick, to give the attachment of the insertion of the muscles, the levator palatini muscle and tensor palatini muscles that opens the Stackian tube. And this tubal elevation masks the vision if you look to the pharynx or look to the nasopharynx from the nose anteriorly. This elevation will mask or hide the pharyngeal recess behind it, which is very important. So when you complete examination of the larynx through the nose, you have to introduce endoscope, 30-degree endoscope, to examine the pharyngeal orifice and the pharyngeal recess. sore throat. What is sore throat? We have to define sore throat. Sore throat, when you divide the word into two parts, throat means anterior aspect of the neck, like this lady referred to it. Sore means discontinuity of a surface. So sore means an ulcer. So if a fluid comes on an ulcer, it will give burning pain. So the definition of sore throat, it's burning pain in anterior aspect of the neck. So anterior aspect of the neck contain different organs, including larynx, pharynx, thyroid, lymph nodes. So any lesion at anterior aspect of the neck, any inflammatory lesion will produce sore throat. When you look at the pharynx in a patient with sore throat, you may find the congestion like in front of you. When you say congestion, you have to know the normal mucosa. What is the normal mucosa in this site, in this organ? So to look at the normal mucosa in this situation, you have to look to the inner surface of the cheek. It is pale pink and wet. So we can quantify the congestion, either it is mild, moderate, or severe according to the color. Pale pink is a normal. And if it is pink, so it is mild. If it is pale red, it is moderate. So it is red. If it is red, it will be severe. If it is deep red, it will be so severe or fulminant. So you have to define the normal, and if it is dry, it will be pathological. Dry, like in Sjogren syndrome, dry mucosa will produce severe dysphagia. This slide shows the etiology of the condition. If a patient with sore throat having a handkerchief and sneezing or blowing the nose, so the etiology here is viral. Viral etiology, this is upper respiratory tract infection. So important item or important slide, 70% of sore throat are viral, 70% of pharyngitis are viral, 15 to 30% only are bacteria, and the most common bacteria is group A beta hemolytic streptococcus. This is a very important slide. So in every case, we have to diagnose, is it, in every case of pharyngitis, we have to diagnose, is it streptococcal or non-streptococcal. Streptococcal pharyngitis and viral pharyngitis. This is the difference between them clinically. Sometimes we have a case like this, but unfortunately this is not presented from the day number one of the lesion. So if a patient have upper respiratory tract infection for 2 to 3 days or even 4 days, and then on the 4th day or 5th day the rash appears. So if patient comes to you in the upper respiratory tract prodroma before the rash appearance and during an epidemic of measles or rubella or so, or you see some cases of measles and rubella in the situation or in the community, please tell your patient to inform you if the rash appears. If he comes before rash appearance, tell him after 2 to 3 days, if rash appears, please call me. This is smallpox, this is chickenpox. Smallpox is not present. Mumps, although mumps is a swelling of the parotids, acute parotitis, so this is a pharynx of the patient. This is the herpes zoster, a viral pharyngitis, viral sore throat, moniliasis, sarcoidosis, fever. Here the same organism, group A beta hemolytic streptococcus, but the X toxin producing strain. There is the patient appear like this during the first 2 days, and then after that rash appears. Other symptoms like acute tonsillitis or acute streptococcitis, it's not differ except on the rash. The same treatment. So We have to categorize pharyngitis as a differential diagnosis, either bacterial, viral, or fungal. And also we have systemic disease that may produce pharyngeal manifestations. A granulocytosis and acute leukemia, if a sore throat recurrent every 2 weeks or every 10 days, and the patient come to you and then takes the treatment and then recurrent again, so you have to request a CBC. Also skin lesion like pemphigus and lichen planus. These are dermatological lesions. Before it appears in the skin, it may appear in the pharynx in more than 70% of cases. So you may diagnose and then refer it to the dermatology department. Deficiency like vitamin C is not present nowadays. Drug intoxication like lead and mercury, which are present inside toxic drugs, also produce sore throat. So the patient on chemotherapy have to be warned that you may feel sore throat and a metallic taste in your saliva. Antidepressant also give sore throat. And sometimes we don't know the etiology, like in recurrent abscess or passage disease. Streptococcal pharyngitis, we have to have what is the streptococcal pharyngitis? Streptococci throat swab proves that it is strep, and pharyngitis means acute inflammation of the mucous membrane of the pharynx and surrounding lymphoid tissues due to strep. So we have to know in every case of pharyngitis that it is strep or not to avoid the complication. So we have to ask ourselves three questions. Which children of pharyngitis should be tested, and how should children be tested, and if the test is positive, what is the treatment? If there is cough, rhinorrhea, and upper respiratory tract infection, so it is viral, so we exclude it, and this is about 70% of cases. The others will be exposed to the test. Detection test, which detects the carbohydrate capsule cell wall of the strep, and if it is positive, no need for throat culture, but if it is negative, because it's not positive in every case, so the sensitivity is not 100%. So if it is negative, we do a throat swab. Treatment, 10 days antibiotics, penicillin or amoxicillin, and rest with. We are not automatically take it in pediatric and we are going to diphtheria. Diphtheria is not present nowadays due to compulsory vaccination. The vaccine is discovered in 1920. It's a very dramatic response for the vaccine. And this is the discoverer of the vaccine, Emil. And this Dr. Shakeout makes a test of susceptibility of the children to take vaccine. This is diphtheria. We are going so fast on diphtheria. Angina, it was called in the past trench fever. Trench fever, Vincent angina is not a fever or a very, very low grade fever, but a very common complaint from the name severe sore throat and halitosis, marked halitosis. It is an acute necrotizing ulcerative gingivitis due to two anaerobic organisms living in symbiosis, Spirochaeta denticola, named after Dr. Vincent, Borrelia vincenti, plus fusiform bacilli. Severe sore throat and marked halitosis with treatment. We give antibiotics that work on anaerobes, and we give hydrogen peroxide to alter the media analgesics. Now we come to infectious mononucleosis. Infectious mononucleosis looks like acute tonsillitis, but if the patient does not give response to the antibiotic, you have to stop and search for another cause. This is not a bacteria. Its main cause is a virus, psychomegalis. This is a picture. So the common complaint is constant fatigue because it is a systemic disease. It affects the reticuloendothelial system of the body. It will reduce generalized lymphadenopathy, hepatosplenomegaly, and it may stay for 1 or 2 months. So rapid onset, constant fatigue, generalized lymphadenopathy, hepatosplenomegaly, 1 or 2 months duration. So you have to check to be sure that it is an Epstein-Barr virus, it is an infectious mononucleosis. Monocytosis first will refer to the disease, but monocytosis have to be repeated in serial manner. So if you found it today 6 and the normal range from 2 to 8, please repeat it tomorrow or 2 days after. If the titer is rising, so monocytosis or the diagnosis will be positive. But if it's still fixed on the same figure, so there is no need to repeat it more than 2 times. We think about lymphocytosis as a response for viral infection. A typical lymphocytosis means a virus is virulent virus. Heterophil antibodies, monospot test or bull panel test, both are agglutination test, but the first using horse RBCs and bull panel using sheep. False positive and negative results. Lastly, we are going to the SURE investigation, Epstein-Barr virus immunoglobulin. We have 3 antigen for the Epstein-Barr. We select immunoglobulin M for the current lesion. We select viral capsid antigen or any others, but you have to request immunoglobulin M for viral capsid antigen for Epstein-Barr virus. Positive diagnose the infectious mononucleosis. The treatment is conservative treatment, but we may give steroid to reduce the swelling or antibiotic to guard against secondary infection. But please avoid ampicillin, that ampicillin may produce rash in infectious patient. This is pus, infectious mononucleosis on the left, slide on the right. This differential diagnosis is mononucleosis after. This is iridocyclitis, genital ulcer, recurrent ulcers. Now we finished our talk today, and this is we refer it to another lecture as ulceration of the oropharyngeal lesions.